Hi, welcome to the Physicians Who Lead podcast. Today, I have the luxury of having two guests, which is twice as good as normal. We have Amar in middle and Dr. Simon middle, and we're going to talk about their careers in leadership development, and we're going to put them on the spot and ask them to tell us how they got here. And then what we'll do is we're going to talk about some topics that are relevant to physician leaders, and go from there. So thank you for agreeing to be put on the spot and talk to me. And I'll ask you one by one to tell me a bit about your background and how you got here.
Sure. Well, first of all, thanks, Kevin, for allowing us to be part of your podcast. It's always exciting to know that there are others like-minded people who are really interested in how we develop physician leadership. So I'm a physician. I've been practicing for about 30 years. I'm a board-certified internal medicine doc, and I've done a lot of things on both the clinical side and the administrative side. So I've been in outpatient, inpatient, critical care, ER. I do geriatrics, nursing home work. I've sort of done a lot of things. On the administrative side, I've been a department chair. I've done clinical operations. I've been the VP of medical affairs in the hospital. I've been a CMO. I've started a practice, sold a practice, and now I do a lot of consulting and coaching work, which I really find fascinating and interesting and exciting. And so I've been coaching physicians individually for the last 15 years, but I've also done organizational work for probably the last 20 years in various capacities.
Awesome.
And I'm Maren, and I have a degree in social work. So early on in my career, I was the director of social services in long-term care and really, really loved working with that population. And then I took some time off to raise our kids when Simon was super busy in his career. And I was able to do some leadership roles in the community with some moms groups and things like that, speaking, small group leadership. And now I own my own private practice in mental health. And really, I have the honor of also working with physicians and other medical providers in the mental health therapy realm.
And what we learned through that process is one, as a physician, we're often good at what we do clinically, and then we're asked to be leaders. And right. Oftentimes being good clinicians doesn't necessarily mean we are good leaders. And the learning curve for leadership can be a little different. And it's a different kind of thinking. It's a different way of sort of processing. And what we found as we started to work together more in the last few years is that if we can bring both the mental health aspects and the psychological aspects, as well as the experience and the learnings that we've had over time, we bring sort of a full package of understanding of here's what some of the experiences are, but also here's what some of the data says, and here's some of what is really helpful in leadership for physicians.
Excellent. Can I ask you both, so you both started off in clinical careers and then have transitioned into leadership. What was it about leadership that drew you in? Like, lots of people stay in a clinical role their entire career and are content with that. Not everybody has the desire to move into a leadership role. What brought you both into leadership?
I think a big part is we really value generosity and we really value having impact. And I get to work with people one-on-one, which is amazing, but thinking about, okay, how do we expand our impact? And really that's why we started SMM Coaching and Consulting, was the healthcare system needs help. There's a lot of real struggles that workers and providers experience. And this was our way to say, we want to show up in the world and influence systems.
Mm-hmm. And I think for me, throughout my career, I really noticed that we have systems that are designed to provide care, but not necessarily foster leadership. And when I think about impact, I love my patients. I love seeing them one-on-one. But from a more global standpoint, there was this gap that I saw between how do we translate good individual relationships into the organization itself, and how does that impact systems? How does that impact culture? How does that actually lead to things like, good outcomes and retention and turnover and all those things that we know it impacts? And through that, when I got my master's in business, I really recognized that we get so task oriented that sometimes we forget there's a relationship that actually needs to be nurtured, which actually leads to a much stronger organization if we can do that in a more global sense. And I think as Martin and I started talking together about what each of us were doing and then bringing that together, we were really approaching it from maybe two different angles, but it was the same coin, right? We were on each side of that coin.
Yeah, and it's interesting because I think so I have been recruiting in healthcare for 20 years. I worked internally with 3 hospitals at various points, as well as I've worked with probably over 100 clients since then. And the what people don't realize is that you can't recruit away problems.
That's right.
Is that, if you've got a bad culture and the engagement of your staff and clinicians is not good, your ability to recruit other clinicians is going to be diminished greatly, right? And inherently, if you are lucky and do hire somebody, your retention is gonna suffer, right? So, where we've partnered with organizations in the past is, to take a look at the engagement and culture before you recruit, to give yourself the best sense of being successful, so that you can recruit and engage. And I'm lucky that, knock on wood, I would say the average tenure of somebody I place is between 4 and 5 years, right? And most of them are, I place them and then they stay for more than that, but I've only been in business for 17 years, right? So, we've got some people that we placed in the first few years that are still there, right? So, so it's very much culturally driven. And how do you think we can support leaders to encourage clinicians to become leaders?
Oh, that's a great question, because I think I can remember when I was on the dark side, right? It was that transition and I remember my colleague saying, "Oh, you've gone to the dark side now." And it was this really understanding of, hey, there's us and them. So to really address how do we encourage leadership by physicians who often feel disenfranchised in their organizations anyway, is to say, if you want to have a voice, if you want to gain back that sense of influence, leadership can really allow you to do that. And I think we're starting to see more and more of that over time. But I also think that a degree doesn't equal leadership, and a training program doesn't equal leadership. It really is, there's a much more experiential part that has to be developed in how to experience being a leader, and recognizing what are the principles that lead to good leadership beyond just sort of, I can read a financial statement, or I know how to do, quote, performance management, whatever that means. But to your point, I really believe that culture is such a big part of how we can say, yeah, we value physician voices, we value physician leadership, and how do we show that within the organizations? I've been part of organizations that say that, but don't necessarily demonstrate that. And that's the disconnect and the dissonance, if you will, within the culture that sometimes we'll see.
I also was thinking one of the pain points that I hear when I'm working with physicians is the balance and flexibility that might be there or might not be there between their clinical role and the leadership role.
That's right.
And administration, takes time, it takes effort. And I think can be compensation issues. I think there can be timing issues. And to offer a structure to physician leaders that feels balanced, where they can stay in clinical medicine if that's part of their desire.
Mm-hmm. Yeah, and that's a great comment, because I just had a client yesterday who is a department head but has no time assigned to administrative support and has no compensation aligned with it. And so, there's only so much you can do. And we either burn people out or we provide some space and options for them.
Well, and it's interesting because so I have the luxury of having placed positions in Canada and in the US. So I've seen a lot of different models over the years. And and it's interesting because often it comes down to worrying about scope creep, right? And and we like to, like, I saw a posting for a psychiatry medical director in Florida, and it says 80% clinical, 20% administrative. And conceptually that's not a bad idea, but realistically how they implement that ratio is interesting, because so you're telling me that, okay, 80%, that's 4 days a week. So 4 days a week I'm going to see patients. Well, if I've got my calendar filled with patients 4 days, that means I only have 1 day to deal with things.
That's
so
right.
Is the expectation that I'm only going to be approached on Fridays to deal with these administrative issues, or will and I see that a lot, is that it's not a 1 day a week job,
Right.
It might be 8 hours a week, let's say, but it's not 8 hours consecutive, right?
That's right.
So building in that flexibility, just like Maren said, is and understanding that it's it's one role with two aspects.
That's right.
Right, is different. And the other thing that I'd like to ask you about is, so I have administer a Facebook group called Physician Leadership Network, and it's a small group. There's only about 60 physicians in it, and we talk a bit about leadership and stuff like that. And one of the concerns that some of the physicians have about moving into leadership is this notion of actually being a leader versus being in a leadership position, right? Like, am I going to be a chief of emerge, but be expected to do whatever the VP of clinical services says, and it's my job to make it more palatable for the physicians, right? So what would you say as a system we need to do to address those types of concerns?
Yeah, it's such a poignant picture that we start painting when we think about, am I actually being asked to have a voice and have influence and impact, or am I now being put into a position where my definition of success is if I do what everybody is telling me to do? And those are two very, very different things. And so in order to change that dynamic, we want to understand what our roles are, right? Is there good role clarity? Is there good understanding of what I might have influence on and impact on? And what do I actually have authority over? Because I think those things get very, very murky in physician leadership roles, especially. And I think partly to your point, it's because, well, we want to protect your clinical time because that's where you produce. And that's why we'll give you 20%, but we recognize that there's actually more, but we'll sort that out somehow different. And so really, and I think the other part of that then is, what is the dyad relationship like? Do I have a strong administrative support that allows me to continue to do good clinical work and to do good administrative work, knowing that there's somebody else who's taking some of those administrative tasks, scheduling my meetings, responding to emails that need to be responded to, or getting my input, or whatever that might be, connecting me to the right resources within the organization, or the right people who, if I have an idea, how does that idea become a reality? And usually that can't be done in isolation. And so what are the people that I need to bring together for those kinds of things?
And one of the things that someone and I we had a discussion about, the communication, right? So when I consult on engagement, for physicians, I look at what I call four quadrants, right? There's your compensation, fairly straightforward. There's your engagement and communication, right? Then there is your resources. Do you have the resources necessary to do the work you want to do? And that could be, nursing, OR time, any number of things. And then the last one is, career development, right? Because are we focusing? So the problem is, one of those quadrants is the communication piece. And I feel like, based on a lot of discussions I've had, they involve the medical leadership after you're somewhat down the beaten path already, right? Like, we're going to do an EHR and we've decided which EHR, but now we need the chief of emerg to, help us implement it in emerg, right? And so then it becomes a case of that physician's not leading you into the selection of what's best for them. That physician is leading, their colleagues to implement something that they weren't necessarily involved in, right? So then that's that dark side aspect of it.
That's
right?
right.
And I worry that too often we see these physicians as our connector to these physicians leaders as our connector to the physician, but not necessarily a physician leader that's providing that physician viewpoint and value to the organization beyond that of just being the go-between with the clinicians, right?
Yeah, and what you're really describing, are they actually more of a liaison, or are they actually leaders? And I think in the systems that I see work well, they develop systems and groupings of leaders that allow them to actually come to a collaborative consensus that then has influence within the organization. And oftentimes, to exactly what you described, decisions are being made somewhere in the organization, higher up in the organization typically, and sort of filtering down to, hey, I want you to implement this, not I want you to have influence on that decision. And I think that's the downside. And I think this is what keeps people out of leadership, is when they don't feel like they have a voice, they don't have influence, they don't have impact. Most of us in medicine, most of us in the healthcare, do what we do because we care. We care. And we don't just care about individuals, we actually care about the system. And so if we, as people who know the system, who recognize the impacts of the system, and now we're not being heard, that becomes very challenging. I mean, another quick example is I had a physician who was working to develop a fellowship for a very specific area that he was developing. And the organization, he had identified an individual, but then the organization said, no, we're not going to use that person. We're not going to recruit that person to the fellowship, without really a conversation on, let's talk about this. What are your concerns? How do we recognize what some of the challenges might be? And what are some of the potential solutions? So oftentimes we see senior levels of leadership making unilateral decisions without really getting input. Now, they may get input from nursing, they might get input from other areas, but the physicians tend to be the last voice that's heard, rather than in what I believe it should be early in that course and early in the decision-making process.
And it's interesting because I worked for an organization with the first hospital I ever worked for, actually. It was interesting because I had two stakeholders, right? I had the physician groups that were looking to recruit to their group, and I had administration, right? So a lot of my time was being a go-between, right? And even though I had no power over either,
that's right.
It was like I was I was like the puppet between the two, the telephone game where one says one and then you tell the other and it changes and stuff like that. And often, though, it was interesting to see that that there needed to be an alignment, right? So what I ended up doing was creating a structure where we did these letters of intent, right? Because in Ontario, where it was historically, what happens is the hospital says, hey, Dr. Middle, we'd like you to apply for privileges, right? So you then fill out a credentialing and apply for privileges. It goes to the medical administration committee to vote yes or no, right? There rarely is any, because they're paid by the provincial payer, there wasn't a offer letter, right? So I was running into positions where physicians would want certain things included in certain resources, and administration wouldn't necessarily be able to commit to those things because there was an impact analysis process that had to come down later. So I created this letter of intent that basically highlighted, it was almost like a job offer that highlighted the expectations, how much OR time were you going to get, what your call schedule was going to look like, and all of those things. And it was my first step at improving communication.
Yeah.
Right. And I think that that went a long way for them, right? Because, you've got to make sure that both party understands what the other one wants, and and how we're gonna do that. And um innately, healthcare workers just keep working, right? Like,
That's right.
in 20 years, I don't know any nurse that said, I'm not going to work an extra hour,
Right.
or social worker that said, I'm not going to take that one extra patient, or physician that said, okay, I'm not going to. Oh, it's 5 o'clock. I'm going to stop this case and I'll finish it tomorrow, right? Like,
That's right. Right.
like you just keep asking and asking and asking. And part of the reason I like working with executives and physician executives is I want to help find the leaders, right? I want to help find the people that are going to say, okay, what's in that physician, nurses, social workers, rad tech, what's in their best interest,
Right.
and how do we enable them? Because too often I think we've been delivering healthcare off the backs of our clinicians,
For sure.
and not enabling them, right? Like, and I worry about using this analogy again, because I think I may have used it on my last podcast, but manufacturing, right? If I have to spend $100 to buy a manufacturing worker a back brace for stability to avoid injury, or for them to return to work, it's no big deal, right? I spend that $100 and get you your back brace, or I get you your shock absorption mat for you to stand on, no big deal, right? But we have yet to apply that same methodology to healthcare. We
Right.
haven't said, what, we're going to implement this to reduce it. And I apologize, I'm on a bit of a rant here, but in the provincial government in Canada just announced $1.8 billion in additional funding for physician teams, right? And all they've done is created a system, right?
Right.
It's like, now more people can be part of a team and get paid as a team, as opposed to getting paid per clinical interaction, right? It hasn't increased their funding, so they're not getting any more money for doing the work. They're just getting it a different way, right? And they haven't addressed the fact that in Ontario, 19 hours a week is about the average a full-time physician does of unpaid paperwork.
Right.
Right. So until we truly start looking at those aspects of what are the, like, it's like you think you're going to throw money at it, but you're not. You're one point. Thank you for the 1.8 billion. The system needs it. Don't get me wrong. I will stand on the corner of every street and say thank you. But the problem is you're not listening to the physician and what their problems are.
And what you're really talking about is there an accurate needs analysis?
Yeah.
Right. I mean, if we had a good system that said, let's look at a needs analysis and let's really understand what the needs are. I think one of the challenges that has happened is we get to anecdotes of what the needs are rather than data around what the needs are. Right. And to your point, you're not 19 hours in a week in Canada. That's fairly similar here. It's maybe a little bit more. And one of the things that we see is we ask more for our clinicians to do with less time, less support, less resource. And the expectation is that they will succeed in that, rather than, hey, let's pause. Let's ask some questions. Are we actually asking for something that's in alignment with what our values are, what the cultures we want to create, and for the outcomes we want to get? And if one of our outcomes is to reduce turnover and improve retention, then just adding more to people's plates is never going to be that answer. That's never going to be helpful. And I think we work with organizations that have started to recognize that, but are also struggling with, how do I create a system that allows for flexibility, allows for the appropriate time for administrative duties, and still has the financial foundation to do that.
Yeah,
we could argue for a long time whether they do or don't have that foundation. but you know, that's the conversation that's being had.
Yeah, and it's interesting though, right? Because when I used to implement tools within clients, I used to always say there's three people in the recruitment equation, right? You've got the candidate, the hiring manager, and the recruiter, right? So anytime I made a decision, it had to target each of those three, right? Because otherwise I wasn't getting the changes at the levels I needed, right? It's like, giving a health system $1 billion is great, but if the $1 billion is not going to hit the other layers, it's not really going to accomplish anything, right? And I think too often there's expenses and money invested in things that doesn't make it all the way to the clinicians, right? Like we're seeing a rise in physicians going to direct primary care, right? And the reason they're doing that is because when you take all the different layers out of the payment structure, they're not getting any less by going direct to the primary, right? They're just cutting out layers of people that take money out of the system. And it's interesting because I've talked to several primary care physicians that have gone that route, and they're able to say, I'm going to have a 400 patient roster, right? My panel is 400 patients. Each patient is going to pay this per month, and all of a sudden their income ends up being better. And they've got less patients, and they can spend more time with those patients, and they can invest in the tools to communicate with those patients better. All the while, the patients, the last one I looked at, was normal copay is probably about $50. So he was charging $80 a month. So, when you get for an extra $30 over one visit, you get multiple visits, right? So, if you're somebody that's got diabetes and you need to monitor your A1C better, and you want to talk to somebody, then you can call them twice a month, and you're ahead of the game, right? So I think there's so much technology and so much innovation happening, but it's a matter of truly understanding how it affects all the stakeholders and really looks at that individual contributor level and say, okay, how do I make the physician's job better? Right? Because if I had $1 million, all I'd say is, okay, well, I'm gonna buy AI scribes for all these physicians so that they can scribe their notes instead of having to look at a computer while trying to do their notes, right? Like it's simple things that actually improve things for the clinicians better, and stuff like that, right? Now, one of the things one of the things you pointed out in one of our previous discussions was something about burnout. How do you think we can address, like, burnout's happening, right? And we can talk about changing the culture and building the culture and stuff like that, but that's a future goal, right? How do we work with physician leaders now for them to address the burnout that they're currently facing, while we hope that the system alleviates these burnout characteristics in the future?
Yeah, this is something that we're actually actively investing in. But I guess I wanted to share an overarching principle of how we approach every single one of our clients, whether it be corporate or individual, is people want to be seen, heard, and valued. And, as you're talking about, where do you put your resources, to keep that principle in mind would make a big difference. You're talking about, primary care, starting their own private practice. That's happening in the US here too. And I think because they know they are seen, heard, and valued in their own, private practice, and they know every single one of their patients can be seen, heard, and valued by them, which isn't always accessible in a huge corporation. So I think even that overarching principle affects burnout or resilience. When people truly feel valued, and different generations generally experience that differently, but when providers and medical employees feel valued, and actually every human, I think we develop more resilience. We show up and shine rather than have the energy drain always happening.
I think also, kind of getting back to the core of your question, if we use those overarching principles, the first thing is, do people actually recognize they're burned out? Oftentimes, especially for physician leaders, because we're so used to sort of putting our head down and driving forward, we don't stop and pause long enough to say, I'm actually burned out. I mean, that actually is not the way typically things happen. And I think of stress and burnout on the spectrum. You know, nobody wakes up and says, I'm burned out. They usually start somewhere, and they start getting all of the additional stressors that then add to that sense of overwhelm, which then leads to that sense of burnout. So I think the first step is, how do I help leaders recognize that they might be burned out? And there's lots of great tools out there to do that. I think second of all is, what is the support? And I think this is where coaching has such a value. We can help people walk through how to move from burnout to resiliency, and that there's some very specific steps to do that. And you know, we've created a program specifically for that because we recognize that that's so important. I think a part of that is recognizing where are my healthy boundaries as a physician leader.
Right.
So, and one of the things that we talk a lot about in the work we do is people who are the most resilient tend to have the best boundaries. And also those who have the best boundaries are less likely to be burned out. And they also the ones that tend to build the most trust. So we recognize that if we can have that, but what we find is most people have either never thought about boundaries or never instituted boundaries because the system has said, we want you to work harder. And that's the message, rather than saying, hey, let's pause here. Let's have some kind of thought around this. And let's think about how we actually want to get things done, rather than just adding work to people's plates. And then I think the other part of resiliency is really about developing that sense of self, that my well-being is actually as important as my caring for other people. And we struggle with this in the healthcare field because we are caring individuals, and what ends up happening is we put all of our energy outward and then have very little for ourselves to actually build our own sense of self and our own sense of resiliency. And that's what leads to imposter syndrome, and that's what leads to burnout, and that's what leads to people kind of dropping out of medicine. And it's all of those pieces. And so there's an individual piece, and then, as you said, this sort of this longer term, how does that connect to the system changing as well?
And it's interesting because I, as a self-employed person, like I used to have this mindset that I had to be attached to my phone 24/7, right? And I found like last night I got several emails in the evening, and my first response was, oh, I'm going to reply to them all tonight, right? And meanwhile, I'm sitting with my wife watching TV and you know, and then picking up my daughter. I'm like, I'm going to put a calendar, so I put a note in my calendar for Monday morning. And I said, Monday morning, I will respond, right? Okay. I like knowing that they're there because I have this desire to plan for Monday morning before Monday morning.
Yeah.
So, you know, I liked reading them, but I also am giving myself the grace to not respond yet.
That's right.
So I'm working on, my dream is at some point at like 8 o'clock at night, put my phone in the kitchen and leave it there. You know, baby steps, maybe I'll get there at some point. It's deciding what time that is, because I have clients in California, I have clients in PEI on the East Coast of Canada. So, you know, time zones are my enemy, right?
Yeah.
So
oh, go ahead.
I was just going to say, you know, it's an example that you bring up about when do you respond. We actually heard this from a physician, and we loved the idea, is that if he responds like in the evening after hours to an email, he says, I'm responding at this time for my convenience, but there is no expectation for you to respond out of your time that you work. And we're like, see, that's boundaries. That's really being seen, heard, and valued ourselves, but also to that other person. And it starts to set a cultural context.
Right. Yeah. And I think that cultural context, again, I mean, we as healthcare workers almost wear a badge of courage, a little bit of, hey, I'm always working. I'm always on my phone. I'm always responding because I care so much. right?
Yeah.
That's sort of the message we get, rather than a message that says, as a good leader, you actually lead by example as well. And your example of setting those boundaries actually helps other people feel empowered, which is sort of an overused word, but empowered to set those boundaries too and say, I really don't need to respond at 11 o'clock at night because my boss has sent me an email. And that becomes then the culture to say, oh, this is okay. But there's, again, the culture may actually be feeding a fear of not that I won't be seen as valued because I'm not responding when somebody sends me something. So that's part of that discussion and messaging that says, we care about you and your well-being because you're a human being, not because you're a worker, not because you produce for us, not because you bring dollars in, but because you're a human being. And that then humanizes what happens in the healthcare field. Because right now, most what we see in the surveys and the information we're seeing in engagement is there's less and less people feeling like they're a human being in a system as much as they are a widget in the system that has to produce or has to keep running.
Yeah, no, and it's interesting because we seem to sometimes lose the individuality,
For sure.
right? And it's interesting because I do a little bit of kind of what I call reverse recruiting, where you work with somebody to help them and introduce them to potential jobs. And often that entails, it's actually kind of a lot of fun, is you sit and talk to the individual about what it is they're looking for. Right. And understanding what's important to them, and then introducing them to organizations that can fill that need, right? Or the prime example is I had a Canadian that trained in the US and was coming back to Canada, and he just wasn't sure what he wanted to do, right? So we talked a lot about kind of what what was interesting to him and what types of rotations did he like and what were clinical issues and stuff that he enjoyed working with. And we ended up almost inadvertently building him a career path that had a bunch of different things, right? So what he works with one of my clients coaching and educating diabetes patients, right? So that's done virtually. He can do that 2 days a week if he wants. And then he told me he had a really big interest in cardiology, so he was an internist. So we put him in, like, we got him a part-time thing in interventional in cardiology, stress testing, echoes and stuff like that. So so he's doing that and loving that, and he's loving the other work. And then he's doing inpatient work with a hospital where he lives, right? So he's basically created a structure for himself with my help of doing the things he wanted to do. And he has the flexibility in his schedule that he's not in any one area, right? So I often tell people that, doing multiple things can sometimes help with burnout because you're not in one place the entirely. And selfishly, I like having consulting conversations, right? Like, it's a different conversation than, am I going to place somebody for you? Am I going to interview somebody for you? So these things provide you somewhat of a break from reality, for lack of a better term, that allows you to diversify, right? So I think those are key and stuff like that, right?
And that requires an organization to be flexible. So right, so I think a lot of times what ends up happening, and I'm sure you've seen this on the recruiting side, is you're recruited for this, and this doesn't have flexibility. Whereas, hey, if I design it myself, I actually can design more flexibility. And that's what I did with my career. I mean, I was very conscious about the fact that I enjoyed lots of different things. And so, I was part of an organization. I left the organization. And really part of that was I want to design something that allows me to work in the areas that I really want to with flexibility. And so from an organizational standpoint, how do organizations design systems that allow for that? So that there is the ability to say, hey, I have multiple interests and I want to do these other things. Can now we create something rather than looking at as I need one FTE doing X, Y, and Z, which is the way a lot of organizations look at it today. So So having a different alternative.
Well, and I think that's a really good point, right? Because historically we look at people do locum tenens or travel nursing, and a lot of the reason that people do these things is because they want flexibility, and sometimes the money's better too.
For sure.
But the reality is that organizations need to have the courage to be employee focused first, right? And I did a manpower plan for a hospital that was going through a growth phase and adding 125 beds. So it was interesting because we took the financial data, so the number of inpatient stays, number of nursing hours per patient day. We took a look at the outpatient numbers and volumes for different services, and we were able to come up with a plan of how many staff you needed to do, right? And the decision was to determine things based on hours of work, not FTE.
Yeah. Yeah.
Right. So we needed to come up with 1,800 hours of work. Right. So how that 1,800 was met was completely different.
Right.
Right. Because conceptually we could get rid of locum tenens firms, which, my colleagues in that space, I'm sorry. I don't think it'll happen. So, nobody send me nasty DMs.
Yeah, you're safe. I promise you.
Yeah.
Yeah.
But it's really just allowing the organization and the people, to almost self-schedule.
Yeah.
Right. And come up and say, okay, I'm going to be a 0.6. I'll give you 3 days a week and stuff like that. But it puts an onus on the organization to have a larger roster of talent, which when you've got scarcities, it's a scary thing, right? Like to sit here and say, oh, we're having a hard time recruiting physicians, but we're going to need twice the number now because nobody's going to work, a 1.0 FTE. Well, the reality is you're going to open your pool.
Right.
Right. So more people are going to come because they don't have to make the same change. Right. A lot of the placements I made were part-time. And why were they so easy? Because the person didn't have to uproot their life.
Right.
They weren't giving up a full-time job or giving up this work, take over this work. They were doing both.
Mm-hmm. And you know what else is so exciting about what you're talking about is physicians transitioning into retirement. Mm-hmm. Because I think we're seeing it now that it's like, I want to keep working some, but I do not want to do this full-time thing anymore. And even this is happening to leaders, and organizations are not well set up in general to have the gradual decrease of hours. It's either you work your full job or you're retired. Yeah. And I love what you're saying because it allows that flexibility at the tail end of a career as well.
And I also think what you're talking about requires that physician leader to be engaged in that system, because we as physicians recognize that transition over time, or even, again, from a generational standpoint, we know that, some of our younger colleagues may not want a full-time FTE, but they want to be involved in multiple areas. Now, as a physician leader, we can bring that voice forward. And that requires me to, as a physician leader, to understand those nuances in what's happening in that space. So how am I being given time to explore that, to understand it, and then to bring that voice forward? And that requires time, that requires energy, that requires resource. And so when we come back to how do we help leaders recognize that there's value in what they're doing, it's to give them that path that says, oh, okay, now I really see that if we're going to need to make a change in the system because of what's happening in the workforce, I get that. That's something I understand now. Now let me help be part of that conversation. And there's techniques to do that well. And a lot of the coaching that both Marna and I do are really to help individuals recognize, how to navigate the politics, how to navigate those conversations in ways that are going to be much more impactful.
Yeah, and I think we have to have this notion of, and I was training a recruiter last year, and I said, I need you to think like a career coach. Yeah. Right. I don't need you to think like, I've got to put this person in this job. I need you to think about how is that person going to be successful? Yeah. And what is it they're looking for? Because when there's a scarcity and the physician, let's say, has the choice of going where they want to go, they're not going to go somewhere they don't want to.
Right. That's
Right.
right.
So let's if you want to work with that physician and make a successful hire, you need to make it in their best interest.
Mhm.
And I mean, too often we rely on things like incentives and signing bonuses and stuff like that. And realistically, often if we focused on that individual's career and then dovetailed that with succession planning and potential leadership opportunities, or even growth opportunities in, it doesn't have to be leadership, right? Like
No.
I know somebody that was a general cardiologist and went back to school to be an interventional cardiologist because the hospital they worked at was getting a cath lab, right?
Right.
So the organization said, okay, well, 2 years from now, when you're done your fellowship, this is what we will have for you, and they invested in that. My guess is they didn't invest financially, but I don't know for sure. So it's really just spending less time talking and more time listening, which from a recruiting guy is probably pretty ironic. Um, but it's really just like, okay, what does this person want? Where do they want to be? And the beauty of healthcare is that, if you take nurses as an example, some nurses stay their entire 30-year career at the same hospital, right? But
Yeah.
what happened is they might have been hired into medicine, and then they went to L&D, or they went to the NICU, or they went to nephrology. And what I used to do with nurses when I hired them was I would sit down and say, okay, this is your learning tree, right? And I'd say, these are the branches of the different areas that you could go into and what's required to go into each of those areas. Right. And often it was as simple as, if you'd go to the college and take a $200 or a $200 cardiac cath or cardiac cardiology course, you can then work on the cardiology floor, right? Or if you do nephrology course, you can work in nephrology. And it was starting that conversation early on so that
Mhm.
they continued to be mindful of working towards things. And I think we need to do that more with physicians,
Yeah.
right? And I have a friend who created a pension plan just for physicians. So he now works with physicians and to try and help them do financial planning, right? And that's his thing, is he's like, we're going to help you from the start of your career plan financially so that you can enjoy your later years, right? Um, and it's just a matter of like having more discussions, right? So, and I think that's my last thing I'll say is, I think that's part of the rationale for me having this podcast, is to have physicians have more conversations
Yeah.
and have the things that you've said will now be out in the world for other people to listen to, and hopefully it'll impact change because people will start thinking about the fact that we need to take care of our physicians,
Yeah.
right? Because if we don't, there'll be nobody left to take care of us.
That's right.
And physicians invest a lot of time and energy just to get to the point where they become a physician, right? And if we don't covet and care for them, then we're in a big hole for a very long time.
Yeah. Yeah.
So
No, I appreciate that sentiment. And I think we definitely agree with that. And it requires, we can't think of a healthcare organization the same way as we did 30 years ago.
right.
We can't, because we have different thinking, we have different resources, we have different technology, we have different
Yep.
innovation, and we have a different generation coming into medicine. And if we don't recognize all of those pieces as an organization, then it's going to be very hard for us to not just maintain what we're doing, but to actually thrive in the environment. And so what we want to bring to organizations is really the idea of, there are ways to thrive here. And and the way to thrive is exactly what you said. You have to be willing to listen. And you may not agree with it, but that doesn't make it any less true. And so how do we then design systems to get to that place, and recognize that the voice of the people within your organization, whether it's a nurse or a doctor, it has value, and we have to have systems that bring that voice louder and clearer to people in leadership, not diminish them.
Excellent. Well, listen, if somebody wants to reach out to you guys about coaching and or any other projects around things like process improvement, and coaching leaders and stuff like that, how do they find you? What's the easiest way?
So there are a couple of ways to get a hold of us. One is through our website, which is smmcoachingconsulting.com. If you want to set up an appointment with us, you can go to talkwithsimonandmarin.com, and that'll actually go right into our calendar. And then we are on LinkedIn, and really look us up. We have a business page on there, SMM Coaching and Consulting, and we are providing resources there, an idea of what we do, but also we want to be able to have conversations as much as we can with individuals who are interested. And think about where you might be in your career. Are you early in your career and not sure what you want in terms of leadership or what impact you want to have? Are you mid-career and really maybe disillusioned and not sure where your next step is? Or maybe you're later career and you've had a great career and now you're wondering, what's my next step? Or if you're an organization and you're wondering, how do I address burnout? How do I address things like culture change? How do I really address things of having that voice of the physician be a prominent voice? We can help with those kinds of changes within the culture and organization. So that's probably the best ways to get a hold of us.
Awesome. And I will say, if anybody is struggling to find you guys, they can always reach out to me, and I will make sure they get on your radar quickly. So I appreciate your time today. I wish you the best, and I'm sure we'll be talking again soon.
Yeah, thanks a lot.
Kevin.